Chalo, I have started the recording also of this. So if possible, I will share the video file on our group and keep. So just in case, if you want to revisit something, then you can do that also, or someone who has missed can utilize the data for revisiting it. So next step, now we import the patient's DICOM data. So we go to downloads, Mustansir Lakdawala, double click. Always ignore this unsupported scans. You just go ahead as soon as the select comes, you go ahead and select.
मामा क्या बोला अभी डेटा क्लास चालू बोले ना.
All right, so tooth removal, of course, we'll have to do one virtual extraction for sure. All right, of this 7. So let's start with that. So no need to be like super duper precise, but you need to be at least uh do it at least the basic stuff. Something went wrong. Okay, let's redraw. Plus sign. Very quickly, we will go ahead and redraw. So one good habit that you should always try to cultivate is, as I had shown during the course, is you try and learn to maneuver the scan as per your comfort and not try and, you know, something is not right. Covering drawn area is either covering the entire scan or going through the whole. Please redraw. Okay. मूड नहीं है इसका. थोड़ा सा मार्जिन चेंज करेंगे इसमें. All right, plus sign. So instead of going into the gingiva over there, I'm going to go over the gingiva. Hmm. So sometimes the solution is very, very simple. Something it was bothering it. So you just redraw the margin. Something somewhere is an issue where the software has closed it. Okay, this is pretty much doable. All right, let's go ahead.
Okay.
Occlusal plane, I generally ignore that. I let the tooth come and then I go here and I approximately place it where I want to. Not wasting a lot of time in. This looks pretty okay. All right, and I'll have a crown on this. So I think this looks good. It's within the patient's arc. Yeah, much better. Much better now. Let's check. Okay, they can go a bit in still. Rotate a little. Squeeze a little. Squeeze a little. And a little more inside. Same with this. All right. Looks good. No need to achieve perfection over here. And click next. I don't want to sit and crop anything. So you hit next again, the panoramic curve, for example, if we get it lower over here where we are working. So Dr. Deepika had asked how to change this curve. So sometimes, very rarely, I mean, in fact, this is the first time that I am ever changing this curve. I have never ever felt the need to change this curve.
So in blue sky plan, we have to set the curve usually.
Yeah, it's quite likely that the curve does not take up very well in blue sky as compared to three shape. So everything is
Okay, sir.
green, perfectly aligned dental segment. And since we are going to place the lower, so yes, let's go ahead. Let's go to orthogonal view and control key. And you see here, I'm going behind. I don't want to go behind. I want to start from my mental foramen. That's the most simplest way to actually mark the nerve or trace it well. All right. I don't care about the anterior loop because the marking is only for myself. See, if we don't start from the mental foramen, no, it's very difficult to trace it from in between whenever you have cases like these where uh, you have something like a D3 type of a bone. So if I am in doubt, I'm going to take the highest point possible to mark my nerve because I don't want to take a chance. I rather stay away from my nerve rather than, encroaching it. I think I've almost successfully crossed my tooth in question. So I'm good. This much nerve marking is more than enough for me, which you can check over here that it covers the entire range that we are working in. So you can hit next and you enter your implant planning.
So now in this case, there is an 8 also present.
Mhm.
So ideally, we should extract it before placing an implant, right?
No. Why? Look at this eighth direction. When I extract this and I place an implant here, I this eight is not going to bother me. And if
Hmm.
it does, I'll remove it when it starts bothering.
Okay, okay.
So no need. See, eventually we have to try and accept and try and follow a fact that uh, the patients should receive the same kind of treatment that we would do on ourselves. And with the same intention, when we explain to them, they understand that, yeah. So let's go ahead and place the six. By default, it's a molar. I would always want to place a minimum of 4.5 by 10 for any molar. So let's go ahead. So it's already come over here. Let's go to the cross section and evaluate. Okay, so let's place it like this. Mm, I want to stay 3 millimeters away from my gingival collar, which this is right now. Tad bit up should be okay. Let me try. So instead of thinking, earlier days you will think, अच्छा इसको measure करता हूँ क्या इसको 12 डाल सकते हैं. Now I'll not even use my brain power to do that. I'll just make it 12 and see that okay, does making 12 give me the liberty to keep 2 millimeters away from the nerve? No, it does not. So I'm going to stick to 10 millimeters. And 10.4.5, 10 by 4.5 is a good number. And I would rather have a decent amount of bone around my implant rather than covering up and making this like a 5 millimeter sort of scenario of an implant. So a 5 millimeter would also be okay, but a 4.5 would do the trick quite well. So let's hide this, the guide tube, and let's have the Drilling cylinders on. Let's go to intraoral. CT translucency reduced. And let's check. Mhm. Okay. So, okay. The position looks decent. It looks quite parallel to this tooth also. Okay. So, this looks good. So let's try. Let's have the CT slightly on. Let's go here. Let's go now to the tangential view. And in this looks pretty parallel. है ना? So everything for this implant is already tallied. Center of the bone, buccolingually. Center of the bone, mesiodistally. Quite centered onto the tooth. And quite parallel and away from this premolar. All right. So considering this point, let's one last thing I want to check is how far from this premolar. So when I have a crown, of course, it's going to come. The space is enough. So let's go and place the 7 now. Same thing, 4.5 by 10. Cancel this because the implant has already come in almost like a parallel position. Let's have the angles between the two implants on just 1.25 or 1.26 degree angle change between the both, which is pretty good. Let's go over here and let's align this first. Okay, so whenever it's an immediate extraction, this is my personal preference. I rather want to go ahead with a 4.5 millimeter implant when I'm going to specially splint it with the neighboring implant and place that implant fully guided with almost above 4.5 or almost above, almost above 40 or 50 Newton centimeter torque, rather than place a 5 millimeter diameter implant and then place it freehand and then have that question mark in my mind whether I will have the necessary stability or no. So let's first check. This is the buccal, this is the lingual. I hope that's clear. Correct? This is the lingual, this is the tongue space. So I want to have it 2 millimeters below my buccal crest. So from here, I want to have it 2 millimeter, which it is almost exactly. See that? So over a period of time, when you start planning it over and over, you get that visual muscle memory. That visual memory to get it in such a way that it's almost exactly 2 millimeters away. So let's have it a little bit more centered. Let's try one more time. How does a 12 millimeter go look? So the 12 millimeter is definitely going to encroach our, space for the nerve. So let's keep it like this. If needed, I can go a little bit deeper instead of a 2 millimeter, maybe some few millimeters more, like a 2.5 millimeters below the crest. And let's check the tangential view. So in this case, if you notice, the primary stability is going to come because the implant is not going to actually enter the path of direction of the natural socket. Can you appreciate this?
Yes, sir.
Oh, very good. I didn't realize a lot of people joined, almost everyone. Excellent. So, Dr. Deepika, were you there? Y'all can unmute the mic if y'all don't have a disturbance in your background. All of y'all. Dr. Deepika, did you see when I changed the arc or adjusted the arc of the scan? Ah, मैं भी क्या बोल रहा हूँ? Dr. Dipali. Dr. Dipali, can you hear me?
Yes, she said yes, sir.
Were you able to see the time or the point when we adjusted the arc? क्या हो रहा है? अच्छा, चैट में लिख रहे हो क्या?
हाँ, चैट में लिख रहे हैं सर वो।
अरे चैट में मत लिखो, माइक वो करो और बोलो, क्योंकि वो स्क्रीन के टाइम पे वो सब मेरा ऑफ रहता है। बिंदास। सी, इट्स sort of like an interactive session where you can stop me at any point of time, and if you have something to add or discuss or anything, or uh, counter upon, as if you have a second school of thought that you want to brainstorm, this would be the platform that you can try and do that. And it's really, really open. Unable to unmute. Okay, why would that be? Asked to unmute. I clicked on ask to unmute a couple of times. Okay,
Okay.
you are able to.
Yes, yes, yes.
है ना? So were you there when we were adjusting the arc of it?
Yes, sir. Yes, sir.
Okay, perfect. Because I remember specifically you asking, but I've never had the need. So honestly speaking, this is the first time I also adjusted that. Okay, so now
Okay.
my thought process as, so one thing that all one, two, three, four, all four of you all have to remember is, and one direction. So who am I referring to? I'm referring to Dr. Deepika, Aisha, Vishaka, and Arshad. Okay, respectively doctors. Okay. So all four of y'all, because all four of y'all are actually not going to be doing the surgeries yourself. So what your continuing education has to be, it has to be, even though you are not going to be planning or placing implants, but you still need to be thinking as if you are going to place the implant. So, for example, if you look at this implant's position, where the guided procedure wins over here is that to create this path is extremely difficult after doing this extraction. I hope you guys agree that when you
True,
remove
sir.
this entire molar, to make your drill pass through and only pierce this much and stop is very, very difficult. But when you're doing guided, the surgeon is able to do this flawlessly. And because the entire engagement is going to come from this 1/3 of the bone, that the
Yes.
implant is going to receive extremely high stability. Now, a lot of implantologists, when they will see your plan, they will be like, Doc, what have you done? Why is your implant like so off? Because when you see, suppose in the panorama also, it will not look really, really straight a lot of times. In this, it's looking decently straight. But when you see prosthetically, look at the mandible as a whole. Do you think it looks straight? See now. Does it look straight?
Slightly. Yes. Yes.
है ना? So, for
Hmm.
example, we will never ever, which we earlier times as implantologists, this is what we used to do. We used to follow the tooth. So, if this tooth was like this, you see how off I am to this tooth. And our
So,
earlier philosophies were to drill in the center like this into the furcation. Are you guys getting me what I'm trying to say?
so one doubt I have.
Yes, please, ma'am.
See, most of the time, while giving virtual
I lost you. Can't hear.
planning, no real socket, most of the time, and we
I lost you in between, Dr. Dipali.
huh,
वापस
am
एक
I
बार थोड़ा,
audible?
sorry. Yes, now you're properly audible.
Okay. Okay. When we give virtual implant planning, no, so we put an implant in furcation.
Infurcation, exactly what I was discussing. That the conventional ways of placing implants were taught.
The path or that inclination. Huh, huh.
Continue.
Hello.
I thought because I lost your voice in between, so that's why I started talking. Please continue, Dr. Dipali.
Okay. So
Are you like
is
in
it-
Wi-Fi or on mobile data?
no, right now I'm on mobile data.
Ah, that's why. Next time I will recommend whenever possible. I'm so sorry for such a short notice, but I have to place this implant in a day or two, and it just struck me that why not ask you guys if there is one or two person also who's free. I'm as it is going to plan. They can just visualize, and it'll be a good revision for you all.
Yes, yes, no problem, sir. So
Yes.
my question is it necessary all the time to follow the inclination of that root? In this
No,
case, root is slightly, the tooth is slightly inclined, and we are
exactly.
placing this implant very straight. So is it
Very straight.
necessary to follow that?
No, so this is what I was discussing that the most of the times, no, if you have people who are not educated in guided protocols, they will always oppose this type of planning because उनको क्या सिखाया गया है ये दांत निकालो ये फर्केशन को पकड़ो और फर्केशन को पकड़ के उसके अंदर करो ड्रिल
Exactly.
है ना that because
Yes.
that is how they are taught. For example, uh, let me know if you
Sir,
can see my desktop right now. Can you all see my desktop? Like, can you see I'm opening some other folder?
um,
Mhm.
Right? You all can, right? Or you
yes,
all
sir.
cannot?
Yes, yes, sir.
है ना मैंने एक फोल्डर खोला हुआ है दिख रहा है ना वो फोल्डर Can you all see the folder or is it stuck on the blue sky screen? Just wanted to know that. Can you guys see that a patient's folder is open? Can someone reply?
Yes, sir.
Yes, sir.
Yes.
Yes, sir, we
है ना
can see, sir.
You all can see no हाँ
Yes.
तो थोड़ा बीच बीच में बोलते रहना because this virtual no I don't like it whenever I can't see faces तो मतलब मुझे मजा नहीं आता है because I can't get a biofeedback on it. So these are very old cases of mine. So this is let's check the where is the detail part properties. This is a 2019 case, okay? Before I entered guided. So let me open one picture and show it to you. So for example, virtual, I mean, a tooth is split and sorry, unfortunately, all these are on the drive, so they take a little bit longer to. No, this was a bone expansion. What I wanted to show you guys was a case where I drilled through the tooth, and is it not that case? Maybe. Yeah, doesn't look like कोई और होना चाहिए. No, not this one. Chando. I can't recollect who that patient was. Coming back to our planning. So, coming back to the discussion, say, all four of y'all, whenever y'all will have, they will expect that you plan this implant and that implant should look like this. Do you guys agree? Do you guys sometimes or when you start more often, this is how you will get the request that अरे doctor आपने ये क्या किया है? Why did you plan it into the mesial root of the tooth? I want to place it in the furcation because everyone believes that only when you go into the furcation you will get primary stability. Does everyone agree over here?
Yes,
Have you
sir.
all
But
come
Yes, sir.
across similar
with the
ideologies? कोई कुछ बोल रहा था मुझे नहीं समझा.
yes, sir. मैं हूँ विशाखा.
हाँ, someone said something. मतलब you wanted to say something. I didn't get you.
Hello.
Yes.
Yes, sir. So, my doubt is, now suppose we are placing that implant straight, even if the tooth is inclined
Correct.
towards mesial root, right? But
Correct.
mesial root shows some periapical infection. So, future implant is going to be very close with that infection, whatever it is. Of course,
Correct.
we'll remove that once the tooth is removed.
Correct.
But is it advisable surgically, and future implant healing will interfere with it or not? That's
Correct.
what I wanted
Now,
to.
correct. Let me expand on that. Let's imagine we placed it in the furcation and not in that mesial root. Okay. We were actually not in the mesial root. Our entry point was mesial. है ना? If you remember. So if you notice over here that I might have the ability to make it 12
I can't hear
millimeters.
you.
Hello. Am I audible? Am I audible
Yes.
to everyone?
Yes, sir. Yes.
Now you're audible.
Okay.
Yes, sir.
Great.
Please continue.
Yes. तो now let's imagine कि ये मेरा बक्कल है. So बक्कल से I need to come 2 millimeters below, which is this level right now. Okay, let's come and see. Now in the tangential view, we are right in the furcation. Agreed?
Hmm.
है ना? Furcation में है ना?
Yes.
Mic on रखो, थोड़ा respond दो तो मेरी speed बढ़े.
Yes, sir. Yes,
हाँ,
sir.
हाँ. So if you notice, are you still into the periapical? Can you appreciate?
Yes,
Yes,
sir.
sir.
You are still in the periapical. ठीक है? अब now let's go and see here. Can you appreciate the kind of angle this has formed now?
Hmm.
Hmm.
क्या किसी
It is not.
इम्प्लांटोलॉजिस्ट को इम्प्लांट ये एंगल पे डालना चाहिए विद द लोअर आर्च
No.
बीइंग लाइक दिस? नो,
No,
है ना?
sir.
So ideally speaking, if you noticed, our earlier planning was based on the patient's crown. We based it onto the patient's crown. So now wherever the patient's crown is going to be, my implant is actually in the center of that. I don't give a damn where the bone is. So now if you notice, can you appreciate now, this is my periapical and my implant is fully outside my periapical, coincidentally.
Hmm.
So, and kaisa hai? So this is another philosophy of thinking that अगर फ्यूचर में ये भाई साहब थोड़े और नजदीक आ जाते हैं तो आई डोंट वांट टू प्लेस माय इम्प्लांट सो क्लोज टू दिस मोलर दैट it will make two things very, very difficult for me. One is क्योंकि as planners future में, you know, when you start planning for people, no, these are the डिफेंडिंग पॉइंट्स यू ऑल विल हैव टू नो के सर और मैम हमने यहाँ पे क्यों इम्प्लांट डाला है. हमने यहाँ पे इसलिए इम्प्लांट डाला है क्योंकि वो इम्प्लांट वो नेचुरल दांत का सेंटर है. कैन यू अप्रिशिएट दैट इट्स द सेंटर ऑफ द सॉकेट?
Yes, sir.
Everyone agrees to that part? And when I
Yes, sir.
say it is almost perpendicular to the occlusal plane if I draw a virtual occlusal plane. If कभी जरूरत पड़ी दिखाने की तो आप यहाँ पे ये टूल यूज करके you can actually draw a virtual plane also. कोई फ्यूचर के केसेस में आई विल शो यू द एप्लीकेशन ऑफ दिस इन मोर डिटेल. इसमें जरूरत नहीं है इसलिए मैंने सिखाया नहीं है. ठीक है? सो लेट्स सो इफ यू नोटिस्ड ये चीज मैंने कभी देखी भी नहीं थी, ये अपने आप हो गई. लाइक दिस बीइंग away from the infection happened automatically. Are these two implants away decently? 1.5 millimeter safety zone, 1.5 millimeter safety zone, and उसके बीच में भी अच्छा खासा distance है. So for example, if I measure implant to implant, I'm like 5.5 millimeters away, which is ideal, more than ideal, है ना? So if you notice,
Yes, sir.
आपको और distal जाने की, posterior जाने की जरूरत ही नहीं है. There is no need to go and tap the patient's furcation, but I want you guys to appreciate little better that this is the boundary of the furcation which is fully intact. Can you appreciate the furcation is fully intact? And the
Yes.
mesial wall, this is the patient's mesial wall. The implant is going to engage into the proper mesial wall. and the osteotomy is also going to be into the mesial wall.
So
तो
can you please show that density का thing
वो भी
which
दिखाता हूँ,
shows
इसके बाद दिखाता
bone
हूँ.
density?
And I am going to schedule one more meeting because this meeting will expire in 5 minutes or something like that. I have 5 minutes
Okay.
remaining.
Okay.
उसको
So one question. So
नहीं मीटिंग चालू ही रहेगी. आप सब लोग
अच्छा.
एक दूसरी लिंक भेजता हूँ, उसके ऊपर क्लिक करना.
Okay.
है
Okay.
ना?
Okay.
मीटिंग विल बी
Yes,
ऑन
sir.
ओनली. आई एम नॉट गोइंग टू स्टॉप, बट फ्री में इतना ही मिलता है. And
So
I
my
have
question.
started the recording also. So what that is going to allow is that it is going to allow me to share it with you guys for a small revision afterwards.
Yes. Yes.
Okay, sir.
इसको schedule करते हैं
So
8:15
can I?
पे. Just 1 minute.
Yes, sir.
Cancel, delete draft. Okay, 8:15 वाली meeting है. Add attendees. Copy to clipboard. Sorry for reading out loud, speaking out loud, because once you enter that mode, you start doing it for everything. चलो, 5 मिनट में ये वाली मीटिंग एंड हो जाएगी. दूसरी मीटिंग की लिंक भेज दी है, तुरंत ही वो मीटिंग पे शिफ्ट हो जाएंगे. ठीक है, अभी एक एक करके. सो कैन यू, so I want to conclude this part that I hope everyone gets it. Why did our planning come like this? One, and it doesn't, it is independent of whether the patient's tooth is where, what is the direction of the tooth, where is the furcation, we don't care. We only care about the prosthetic center, and then we work backwards from there. One. Second, this is the primary reason why our guided implant planning will give the doctor at least 50 Newton centimeter torque, because at the end of the planning, they will not have a full khacha. What most of the dentists forget while planning implants is, तुमको ऐसा लगता है कि तुम फर्केशन इज द ओनली बोन लेफ्ट, इसलिए तुम जाके उसमें ऑस्टियोटोमी प्लान करते हो. बट व्हेन यू प्लान द ऑस्टियोटोमी इनसाइड द फर्केशन, तुमने तो पूरा फर्केशन खा गए ना. A 4.5 millimeter drill, when passes through the furcation, the entire furcation is gone. There is no
Right.
furcation left anymore. Do you get my point?
Yes, sir. Yes, sir.
तो ये कैसा है? दिस इज अ कंप्लीट माइंडसेट शिफ्ट फॉर अ लॉट ऑफ डेंटिस्ट. एंड अगर आपका होमवर्क अच्छा नहीं होगा, तो यू वोंट बी एबल टू एक्चुअली कन्विंस अ डेंटिस्ट टू गो विद दिस प्लान, एंड दे विल फील कि नहीं नहीं, इनका अप टू द मार्क नहीं है. विद दिस प्लानिंग यू कैन टेल द डेंटिस्ट, सर एक केस मेरे लिए, एक केस ट्राई करो, आप अच्छे से एक्सट्रैक्ट करना. एक्सट्रैक्ट करने के बाद गाइड रखो, गाइड रख के पूरी की पूरी ऑस्टियोटॉमी करना. 2 से 3 मिनट में ऑस्टियोटॉमी हो जाएगी. एंड जैसे ही वो हो गया, पूरा का पूरा इम्प्लांट प्लीज गाइड से ही डालना. और इम्प्लांट डालने के बाद, गाइड निकालने के बाद, आपको उसको एक सिंगल टॉर्क भी नहीं देना है. They shouldn't be torquing the implant a single turn. I am guilty of this thing, doing it for over 50 implants. क्यों you have that thing, you know, एक और एक कर लेता हूं, बस एक ट्राइट कर लेता हूं. जैसे whenever you will always separate your rotary file, जब आपको एक बार, you know, once that red color, एक बार लास्ट घुमा देता हूं, तभी वो फाइल टूटती है. नॉर्मल केस में नहीं टूटती. तो it's the same logic. The implant goes, flattens out completely through the guide. उसके बाद गाइड निकालने के बाद ना वो इम्प्लांट को टच करना है. The only thing they can do is decide whether they want to put a healing abutment or they want to put a cover screw. That's their choice, but they will not take a ratchet and they will tighten the implant or loosen the implant, nothing, because then that implant can move, which you don't want it to. Is this part clear to everyone?
Yes,
So,
sir.
is this the thing for extraction socket only, or generally also we need to follow this?
Extraction में ही apply होगा generally ये. This
Okay.
rule
So,
notes
so like here, Like here, if we consider implant at 6, tooth
Ha,
number 6,
correct.
I guess 3 6. So it is advisable while after removing the guide, we can give our final torque over there and
Yes.
not
Yes.
to the 7.
For
Okay.
7, the doctor has to compulsorily place the implant through the guide. For
Understood.
6,
Understood.
if at all they decide, there is no logic of putting it has got recorded also. I will share it with you guys just in case if you want to refer it to. Okay. And so, correct. Can I start? Who's
Yes, sir.
left? I think Vishaka is left, no?
Vishaka, ma'am. Yes.
Uh, can someone give her a call once and tell her?
Yes, sir. Yes,
हाँ,
sir.
तो नेक्स्ट डाउट उसी का था. बट डॉक्टर दीपाली, आपको आई होप दिस पॉइंट इज वेरी क्लियर टू यू.
Yes, sir. But
हाँ,
so one I have one doubt.
प्लीज.
In this case, the furcation area is intact, but in
उसके साथ ये
नहीं, क्या हो रहा है?
may I continue?
हाँ, सॉरी. आई हैव ऋत्विक, आई हैव म्यूटेड यू. यू कैन अनम्यूट इट वंस योर बैकग्राउंड नॉइज इज गॉन. डॉक्टर दीपाली, यू गो अहेड.
Yes. So in this case, the furcation area is intact, but most of the time we are getting cases with furcation involvement. So in such a cases, the same implant planning should be suggested.
यस, माय पॉइंट
Okay.
इज कुछ भी होने दो, कुछ भी.
Hmm.
This is the only prosthetic possibility. Can you appreciate that part?
Yes, sir. Yes.
Anywhere I move from here, I am not in my prosthetic center. ज्यादा से ज्यादा मैं थोड़ा सा खिसक सकता हूं इधर उधर, थोड़ा सा, very little. But
Right.
if you appreciate this part, let me completely make it disappear. This is the absolute center. Can you appreciate?
Yes, sir.
At the max में थोड़ा मीजल आ सकता हूँ, शायद थोड़ा बक्कल जा सकता हूँ, बट वो
Hmm.
दांत रोटेटेड है थोड़ा सा एंड मीजली इंक्लाइंड है.
Right.
तो अगर फ्यूचर का क्राउन जब इसके ऊपर आए, दिस इज द प्रूफ दैट फ्यूचर का क्राउन भी ऐसे ही आएगा. रेट्रोमोलर
Hmm.
पैड स्टार्ट हो गया यहाँ से, यहाँ पे थर्ड मोलर है. हम कभी इस पार्ट को एनक्रोच नहीं कर पाने वाले हैं.
Right.
तो दिस इज लाइक द
Yes.
एब्सोल्यूट सेंटर ऑफ इट.
Hmm.
देयर इज नो अदर वे टू प्लान दिस. हाँ, क्या कर
But
सकते
most
हैं?
of the time, sir,
हम्म,
most of the time when we go more mesially, then we are getting enough bone. And near to the furcation area, there is, the height is not that sufficient. So in such a cases, inclination is recommended, or we put an implant in a straight way, just like this.
can you repeat little bit like what in the where the level
Okay.
is down?
See,
I lost you in between.
okay. So see, in this case, the bone is sufficient to place an implant. But in
Correct.
most of the cases, those cases I'm getting, the on more mesial side. I mean to say more towards the 3/6 implant.
Okay.
We have placed 3/6 implant, right? So
Correct.
more towards the mesial side, we are getting enough bone. But in some cases, most of the time, perio cases, there is if furcation involvement is there, the
Correct.
the bone height is below as compared to the the crestal height. From the crest, we are measuring the height from crest and to the superior border of the canal,
Correct.
right?
Bone
So
height
in
is
such a
less of
cases,
what, ma'am?
in the furcation area,
In the
now
furcation
in
area,
this
but
case,
the crestal bone
huh,
is less or the furcation is down?
the furcation is down.
वो तो natural है. Furcation is always below
हाँ,
the
तो
crest.
ये केस में हमें स्ट्रेट ही रखना है इम्प्लांट, या थोड़ा इंक्लाइन करे तो चलेगा?
See, चलेगा सब कुछ. At the
हम्म
end, you guys have to understand that if your dentist who wants
हम्म
to do that, just one moment.
हम्म.
हेलो हाँ
Aisha, are you
अच्छा
getting
एक मिनट
this
હું
now?
આ લોકોને આપું છું શ્રુતિ દેખો
Yes,
જરા
ma'am.
હા
Yes, ma'am. I'm there.
Okay.
so see the furcation is always at a lower level than your crest. If the crest of the bone, either buccal or lingual, generally always buccal, is below the furcation, then the surgeon has to really think that, boss, how am I going to manage the loss of bone? Okay.
Yes,
So
got it.
apna
Yes.
our job is to report. So for example, you will give this as the first plan. If they feel that something needs to change, then it's
Okay.
honestly speaking, there is no point fighting. You might as well give them, show them what are the repercussions. Like, for example, that if I want or if I have to actually plan it slightly to manage or complement something like this, slightly, not too much.
Hmm.
This is the implication that it is going to have when you are managing the prosthetic part. This is what we have to show the dentist.
Yes.
Right.
Yes.
So
got
that
it.
is why I was suggesting to you guys is वो जो सर्जिकल टेम्पलेट बन के आता है ना, उसके बदले में you guys need to try and come up with some innovative way where you're able to get the dentist on board visually with you for about 5 minutes, जहां पे इम्प्लांट ये स्टेज पे प्लान करके रेडी है. अब इस स्टेज पे
Right.
द डेंटिस्ट हैज टू कम ऑन बोर्ड विथ यू फॉर 5 मिनट्स, जहां पे आप दिखाओगे कि सर मैम ये है हमारा फर्स्ट प्लानिंग. So this is the prosthetic planning for this case. Everything is defended that यहाँ पे ये space ऐसे रखी हुई है because एक crown आने वाला है ना? There is a crown missing on this. This is not how the tooth is crown prep किया हुआ है previous bridge का. So that space is kept. So this is the prosthetic center for this. This is the prosthetic center for this. And with this prosthetic center, if we want to go ahead and place an implant, this is how it is placed in the center over here. And this is the tangential view. The good part, so isko bolenge hi nahi, the good part is with this position you will come out in the absolute prosthetic center in future, and you will not have to worry about primary stability because it will come from the entire engaging of the mesial wall, apical, 1/3 in the mesial bone, and the entire coronal 1/3 of the furcation. All these three things combined will give you the primary stability and simultaneously will completely skip the periapical, where you will not, your implant will not go and enter the periapical pool. Is this as a reason convincing enough? है ना?
Yes, sir.
ओवरऑल तो वन मोर आइडिया, अभी मैं जब ये कर रहा था, व्हाट यू कैन डू इज, मैं कैसे कर रहा हूँ जूम कॉल पे अभी, व्हाट यू गाइज डू इज यू ऑल ऑल्सो रिकॉर्ड अ स्मॉल क्लिप लाइक दिस, वेरी जूम्ड इन, ताकि तुम हर एक चीज उनको क्लियरली ऐसे दिखा सको ऐसे, एंड शो इट एट वेरी नाइस जूम लेवल, एंड देन सेंड दिस वीडियो क्लिप, जो कोई नहीं करता है. कौन है? हसमुख भाई. अच्छा अच्छा अच्छा. सो व्हाट विल हैपन इज कि उनको जूम कॉल पे लाना ना आपके लिए मुश्किल होएगा, बट इसमें क्या हो गया मालूम है, ये वीडियो क्लिप इज लाइक अ स्टॉप इन टाइम. जब उनके पास सब पॉइंट्स आ गए, जो पॉइंट एज अ सर्जन उनको ध्यान में रखने हैं वो सब आ गए, सर्जरी के पहले वो 5 मिनट पहले वो क्लिप खोले, टक 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 सब रिवाइज कर ले, खत्म हो गई बात.
Yes, sir.
है ना? डॉक्टर
Right.
अर्शद,
Yes,
आप
sir.
भी जो वो सोच रहे थे ना कि इस छोटी छोटी ये चीज करने की, क्या बोलते हैं, वो क्या बोलते हैं, सर्जिकल का टेम्पलेट बनाने के लिए कि उनको कौन सी ड्रिल करनी है ऐसे, तो
Yes, sir.
समथिंग लाइक दैट कैन बी कंबाइंड विद दिस. ऐसा कुछ आउट ऑफ द बॉक्स सोच
Video.
सकते
Okay,
हो
sir.
और ऐसा कुछ कर सकते हो कि इसी एक ही वीडियो क्लिप में सब आ जाए. इधर आप उनको एक्सप्लेन कर दे, या तो जरूरत पड़ी तो यू कैन यूज सम फीचर्स लाइक एनोटेशंस लाइक दीज. फॉर एग्जाम्पल यहाँ पे आ गए, एंड अरे किसका आवाज चालू? कौन टीवी देख रहा है रे?
It's my son.
अच्छा, जस्ट किडिंग. सो यहीं पे कहीं पे क्या प्रॉब्लम था? और यू कैन गो टू स्क्रीनशॉट एंड जस्ट एड इट इन द स्क्रीनशॉट कि ये आपका ड्रिल प्रोटोकॉल है. तो इंस्टेड ऑफ showing diagrams, you can put it like in simple words कि सर फर्स्ट आएगा pilot drill 6 mm, then pilot drill 10 mm, then 3.6 10 mm, then 4 10 mm, then 4.5 10 mm, and then implant through the guide. खत्म बात. एक ही वीडियो जिसमें सब कुछ आ जाए. नाउ गोइंग बैक टू, इज डॉक्टर विशाखा बैक ऑन दिस? वो नहीं है,
No,
उसने
sir.
पूछा था, बट आई एम गोइंग टू गो अहेड एंड शो यू गाइस द हाउंसफिल यूनिट. ओके,
Hospital. Yes.
तो कहाँ गया? हाँ, ये आ गया मेरा, सॉरी, ये आ गया मेरी बोन डेंसिटी, जिसको मैंने ऑन कर दी यहाँ पे. ओके, सो आई कैन एक्चुअली गो अहेड. क्या हो गया है आज इसको? Something is fishy today. See, right now it's showing in real time as and when I rotate it, that what kind of bone is going to be around my implant. That's one thing, but I will also show you guys कि वो कहाँ गया. Where you can actually measure the Hounsfield unit also. और या तो उसको कट सेक्शन पे जाता है ना, उधर के उधर ही दिखाने लग जाता है वो. 1 मिनट. अरे क्या हो रहा है? It shows here also as a cross section where it comes. चलो, अभी मेरे को नहीं मिल रहा है, because I understand that you guys will require it to mark and give it to them. So these are some extra features over here which at a later date you can try and explore. उसको अभी हाथ मत लगाना other than the measurement part of it. Okay? ये रहा. अब वही मैं सोचूं कहाँ चले गया. See, can you all appreciate? So wherever
sir.
you want to add markings, you click. Go in, go again and add one more marking कि यहाँ पे मुझे डालना है या यहाँ पे डालना है या जहाँ पे भी. Is this clear? The same will apply
Yes.
everywhere. Over here, वही मैं सोचूं एकदम सामने था, कहाँ चले गया. Okay?
Yes, sir.
Yes, sir.
चलो, तो आगे बढ़े. Does this position look okay prosthetically also? है ना?
Yes, sir.
Yes,
Looks
sir.
like an acceptable position. Let's do one last thing. Let's get them as parallel as we can. Okay? Now in this case, I have the provision to actually, मेरे पास इतना सारा बोन है, I can align both of them as much as I want. Okay, ये बढ़ने लग गया 64 से, तो इसको ऐसे ही रखता हूँ. अब इसको थोड़ा सा, let me select this implant and then tilt this one slightly. See, अब नहीं हो रहा है उससे ज्यादा. Yeah, so 35 is the closest, 0.35 is the closest that I've come to its parallelism. This is pretty good, I feel. One last check before I go. Cross section. So this is which implant? This is my 6. I am about 3 millimeters away from my soft tissue, which is where I want to end to establish the biologic width. In this case, I don't care about anything else. Decently centered. If I would have wanted, I could have actually tilted it mesial or buccal, but otherwise prosthetically it looks okay. So let me go ahead and select this implant. Come back to cross section. I am about 2.5 millimeters below
Right.
below my buccal crest, which is where I want to end it. If at all you have any doubt, you can always go a tad bit in, considering that the extraction is going to be difficult. Like this tooth, we have to anticipate that the extraction is going to be a difficult extraction. Okay? So, of course, that's not your job. That's the job of the dentist who's going to, to anticipate that. And they should definitely study their own CBCTs and not only rely on this. Okay, so at this stage, we go ahead and hit next. Now I will get this part of my occlusal plane into my view and select insertion direction from view. Wait for it to load. Sometimes it takes a lot of time. Then go ahead and start the guide planning. So one important thing for all you guys is that when you get scans from patients, scans from doctors, they need to have a perfect buccal surface. Can you see the proclination? At least
Yes,
60 to
sir.
70% of them will send you shitty impressions where there will be complete drag marks over here. Please do not accept those impressions because your guide will not fit and eventually you will take the blame. Am I really clear with you guys?
Yes, sir.
Yes, sir.
हाँ, तो उनको बोलना है कि सर और मैम, आई एम रियली सॉरी, बट प्लीज एटलीस्ट एक इम्प्रेशन जो है वो ढंग की देना आपकी रिस्पॉन्सिबिलिटी है. सही बात है कि नहीं है? तो कई बार कुछ लोगों को सॉरी बट बुरा लगेगा, बट वो दैट यू ऑल हैव टू मेक श्योर बिकॉज दैट्स गोइंग टू कॉम्प्रोमाइज योर एबिलिटी टू गिव अ गुड रिजल्ट. फॉर एग्जाम्पल, कैन यू अप्रिशिएट हाउ मच आई हैव स्कैन्ड ओवर योर? अगर वो दांत
Yes.
को सट
Yes,
के
sir.
होगा तो गाइड को जगह ही नहीं है, उसको समझ में ही नहीं आएगा कि कितना एक्सटेंड करूं. तो दिस एक्सटेंशन हैज टू बी देयर lingually also, buccally also, and distally or posteriorly also. I hope I have made myself very clear with that part.
Yes, sir.
तो स्टार्टिंग में मुश्किल होगी. प्लीज टेक अप cases and be very clear that sir ma'am the guides are very accurate. तो प्लीज अगर आप थोड़ा टट्टी जैसा इंप्रेशन दोगे तो टट्टी जैसी ही गाइड आएगी. तो थोड़ा सा आपको प्यार से बोलना है. मैं बोल सकता हूं क्योंकि मुझे किसी को जवाब नहीं देना है, बट आपको थोड़ा प्यार से बोलना है क्योंकि आपको उसको आगे जाके अपना बिजनेस बनाना है. अब नाउ हु इज गोइंग टू टेल मी दैट आई टॉट यू ऑल दैट यू ओनली नीड टू क्रॉस द मिड लाइन स्लाइटली, और अब मैं तो जाके दूसरा प्रीमोलर कवर कर रहा हूं. क्यों?
So for stability.
Because of insufficient this
है ऐसा मत बोलो यार.
insufficient
है
Sir,
मेरा
ingrown
नीचे तक.
stability.
उसके नीचे
Sir, stability, sir.
1.5 मिलीमीटर जितना
Cross
कवर किया है
stability.
मैंने. स्टेबिलिटी तो देखो, टूथ सपोर्टेड है. स्टेबिलिटी तो ऐसे भी आने वाली है. मैं 2 दांत का करूंगा ना तो भी स्टेबिलिटी आएगी. कुछ और सोचो, इस केस के पर्टेनिंग सोचो जो आप लोगों के केसेस में नहीं था पर इस केस में है. देखो डॉक्टर अरशद, ऐसा रहेगा, बोल नहीं रहे हो तो म्यूट कर दो. सो कैन यू अप्रिशिएट मेरा अंडरकट कितना है? मेरी इंसाइजल एज छोड़ के एवरीथिंग एल्स इज माई अंडरकट.
yes
समझा?
yes
अगर
yes
इसको मैं यहां एंड करूं, ये पूरी की पूरी गाइड हवा में है. कैन यू अप्रिशिएट? ये देखो, उसको
yes
इंसाइजल एज छोड़ के कहीं पे भी कोई कांटेक्ट है ही नहीं. तो देर इज नो बक्कल स्टॉप ऑफ एनीथिंग. तो अगर इफ आई प्रेस द गाइड फ्रॉम योर, इट विल एक्चुअली लिफ्ट फ्रॉम बिहाइंड.
seesaw movement
सीसॉ मूवमेंट हो जाएगी.
Hmm.
इज दैट पार्ट क्लियर?
Yes, sir.
yes
हाँ, थोड़ी सी इसको थोड़ा सा नीचे और एक्सटेंड कर देता हूं. दैट इज वाई आई हैव मेड दिस चेंज ओनली फॉर दिस केस. तो ये आंखें अपने को खुली रखनी है. So there are no fixed rules for anything. There are only whys that you have to answer. है ना? I hope this part is very, very clear to everyone.
Yes,
Yes,
got
sir.
Okay, once done, I don't need a glue channel for this case. So I'm not going to sit and do that. And I don't want any marking. So I am going to personally proceed further. Okay, add one window over here, make it slightly wider. Add one more window over here or somewhere in between. थोड़ा सीधा होएगा तो खड्डा भी सीधा होएगा. The best part is you can keep changing this even after you have added it, which was a pain in blue sky. Okay, I think this looks good. I have the canine over here and I think the canine over here, which has visibility. I don't need any more visibility. I know the fitting is going to be very, very good. So I generally try to erase the last name so that it doesn't take too much space and add the ID tag. Okay, looks good. ठीक है?
Yes, sir.
Yes, sir.
Let's hit next. Let's approve and then let's slice it for 3D printing. So if you notice, I have a i9 with 32 GB RAM and 12 GB dedicated graphic card. उसमें भी ये ऐसे चलता है. तो you can imagine कि अगर थोड़ा और कम रहेगा तो वो कैसे चलेगा. So one more trick that I will share with you guys is that as and when you start designing a lot of surgical guides, please try and sort your data very, very well. For example, if you notice there is a surgical guide folder. In my surgical guide folder, I do have different doctors for whom, for example, if I have done some planning and all their cases then go inside that doctor. So this is how you can categorize. If it's my own case, it comes outside. Okay, and it gets saved over here. Once done, simultaneously, I will open the Cheeto box over here. This folder is open. I'm going to close this and let's start slicing. Cheeto box is visible to everyone. Cheeto box is visible. Guys.
No, sir.
No, sir. No, sir. Not yet.
Cheeto box नहीं visible है? तो कितना
Yes, sir.
lag है?
Now it's visible.
Oh God, that means there's so much of lag.
Lagging. Yes, that's lagging.
Because Cheeto box तो कब का खुल गया है? I will go little slow. ताकि मैंने settings खोले वो दिखे?
Yes, sir.
Yes, sir.
Yes, sir.
चलो तो I will select mini 8K. I will drag and I will go to the profile of my resin, which is D-Tech Surgical Guide. आज रात को after this I mean session, I will send you guys this setting. Okay? जो आप
Yes,
copy
sir,
paste कर
please.
देना अपने printer में. ठीक है? Exact
Okay.
same to
Yes.
same. जो last की जो speed है ना, this you don't change. This you let it be. अगर आपने 4K लिया है तो 4K हिसाब. This is for mini 8K. Okay. So Dr. Dipali, for you this will work. Dr. Arshad,
Yes,
when you
yes.
buy a 4K, ये speed मत alter करना. वो जैसे ही software ने set किया उसको
Okay,
रहने
sir.
देना आप. ठीक है? So now let's
Sir,
open the
for
folder.
4K and 8K, it is different, the specification or speed.
Yes, yes. The resin profile are sort of interchangeable, sort of. But the speed is different. Okay, we drag drop this.
Okay, sir.
क्या नीचे आएगा, एंटीरियर या पोस्टीरियर?
Anterior. Anterior.
एंटीरियर नीचे, ठीक है. Go to this, select all, come back, slice, 1 hour 44 minutes, put the pen drive in. If you notice, 3D printing, once you understand and once you set your parameters, is a piece of cake. Should not take more than 2-3 minutes. Okay, selected USB drive, save the file, and done. ये क्या हो गया?
Okay.
Everyone saw, right?
Yes, sir.
Yes, sir.
वो दिखा ना? हाँ. Okay. So after this, I have my aligner case for whom I am going to set my models vertically. So on Sonic Mini 4K, I'm going to fit about 7-8 models. If at all you all wish to see, I will have to change my PC for that. So I'm going to stop sharing over here. I will start the meeting on that. If at all there is anyone who wants to see how, because I have not taught you that. So if at all, क्योंकि मैं कर ही रहा हूं, तो I thought I will show you guys. अगर किसी को देखना है तो एक नई लिंक जनरेट करता हूं. आई एम सॉरी फॉर द ट्रबल, बट वो लैपटॉप से आई हैव टू लॉग इन बिकॉज दोज केसेस आर ऑन माई लैपटॉप. तो you all join in. I will show you guys how to vertically slice and what are the intricacies and where to add supports, because auto support does not work very, very well there. Okay. So I hope this session was helpful to you guys. I have tried to record it. If at all there is anyone who wants the recording, you let me know. I will share it with you. Okay.
Yes, sir.
Yes, sir.
So I'm sharing a link. If at all, is there anyone who wants to see that?
Yes, sir.
Okay, so link,
Yes,
I
sir.
will
We
share
will
the
watch
link
it.
and you all have a
Yes,
look
sir.
on at that. Okay, 2 minutes. I'm stopping this.
Okay, sir.
Okay, sir.